and we will continue with the topic which we announced earlier regarding long QT. And I will have pleasure to summarize our recent findings and recent paper. Let me share the screen. I hope you see my screen. So long QT patients obviously could be treated by ICD. As you heard from Professor Wilde today and other talks, there are a number of risk factors which could be considered in patients who might be at risk for sudden death or aborted cardiac arrest, especially QTC, which could be above 500 or 550 milliseconds. We already indicated that male sex in childhood and female sex in adulthood carry a risk of cardiac events in this patient population. We learn also that syncopal events significantly increase risk of subsequent aborted cardiac arrest or sudden death. And we also learn that LQT3 genotype is associated with increased risk of those lethal events in childhood and after age 40. There is no evidence of such association between age 18 and 40, at least in our database. But I would like to stress what Dr. Wilde already pointed out. Implantable cardioverter defibrillator is, as you see, at the bottom of the list of therapies in long QT. Preventive measure like lifestyle modification, he indicated, avoiding QT prolonging drugs, and we'll talk about it a little bit more during discussion because you provided a number of good questions regarding QT prolonging drugs. Anti-adrenergic therapy, beta blocker is the mainstay of this therapy, but cardiac denervation could be exercise too. And as you heard from Dr. Wilde, there are some patients who might benefit from gene-specific therapy, LQT2, LQT3, with mexidatin and flecainide compounds. Pacemakers could be used, but nowadays, since ICD includes also pacing function, it's less frequent than pacemaker alone is being implanted. So let's speak about implanted cardioverter defibrillator a little bit more. About 10 years ago, Dr. Jons, who originally is from Denmark, who spent 2 years with us here in Rochester, he did very nice study looking at risk of arrhythmic events and beta blocker therapy. And the dotted line below the two other lines is the best graphical presentation, how effective beta blocker could be reducing events in patients who had some syncope, first syncope. And patients who happen to have syncope on beta blockers, they still have risk similar to those who are not treated. This is important observation since we wanted to identify patients who might potentially be protected by other treatment like ICD. In 2003, we reported 125 patients from our LQTS ICD registry who had implanted ICD. And as you see, in cumulative 4-year period, there were about 17% of appropriate ICT therapies in this patient cohort, meaning around 4% per year on average. What we wanted to also discuss at that time, what about so-called secondary versus primary prevention indication? Secondary means that somebody already had cardiac arrest, required resuscitation, and therefore that such person was at very high risk. But we also look at people who didn't have cardiac arrest, but had syncope, didn't require resuscitation. After syncope, these people came back without need for typical heart massage. And those patients who happen to have those syncope on beta blocker had very similar level of appropriate therapies to those who already had cardiac arrest. So this particular observation stressed that if somebody develops syncope while religiously taking beta blocker, this is already sign of high risk. Dr. Beaton, who is cardiologist from Israel, who spent with us 2 years also several years ago, he put together very nice analysis looking at patients who were not surviving cardiac arrest, but who might have had syncopal episodes. So in this analysis, we excluded people with cardiac arrest for whom ICD is already clearly indicated. So we published this about 2 years ago in Europace, one of the electrophysiology journals from Europe, and we developed risk score. As you see in the table on the right, there were points given for QTC. It would be less than 500 to 549, 1 point, and over 550, 2 points. Prior syncope while on beta blocker gives you 1 point. LQT2 or multiple mutation give you also 1 point. When this score was computed for this close to around 200 patients, we're able to identify that some of them obviously differ in terms of risk of appropriate ICD shocks. And as you may notice on the left, there were people who had score of 3 or more, who had a very high risk in range of 40 to 50% at about 5-year follow-up, followed by the other group with score 2. So this kind of score will help guide physician in patients who, again, didn't have cardiac arrest, which prompts immediate implant, but looking at patients who might have still some doubts whether they should be implanted. So the score was not only analyzed for first ICD shock, which is the presentation on the left, but also for recurrent ICD shock. And this figure on the right is presenting number of appropriate shocks per 100% years. So this is almost like percentage. So what percent of people could have this kind of shocks? So as you see, score again worked not only for first ICD shock, but also for recurrent. So this was further reassuring us that probably one could use this score successfully. And if you have 2 or 3, it means that your risk is really high. 0, 1 is definitely smaller risk. And this particular approach could be really helpful for physician making final decisions. We also, I mentioned, had pleasure to have another colleague, Arva Yunis, who work on outcome of ICD patient by sex. And as you know, we may have more women in such cohort because females above age 18 are particularly prone to develop events, especially if we speak about LQT1, LQT2 cohorts. So not surprisingly, this analysis included majority of women. And as you see over here, 15-year risk of appropriate ICD therapy taken from this so-called Kaplan-Meier curve was very similar. So if you are at high risk, doesn't matter whether you are male or female, your risk is high, 25% in women in here and 32% in males. So altogether risk quite high, requiring obviously preventive measure in such patients. This concept of indication for ICD is addressed by a number of so-called guidelines, and such documents are published periodically and updated periodically, both in US and Europe. And they try to reflect more recent data from various studies. So this one happened to be from 2013. And as I mentioned to you, prior cardiac arrest is clear class 1 indication for ICD. And no doubt if somebody survived, was lucky enough to survive cardiac arrest, they should immediately receive ICD. If somebody has recurrent syncope while on beta blocker, what we showed in 2003 and subsequent analysis, this already is also high risk, and it has so-called class 2A, somewhat lower than class 1, but still majority of these patients should be considered for ICD. And the third box is asymptomatic, not treated with beta blocker. And in this case, it's really rather not ICDs, rather not indicator. But very recently, we had the pleasure to have very talented PhD student, Meng Wang, Dr. Meng Wang, who spent with us also a couple of years. And we worked with her on the analysis of mortality in entire our long QT cohort of about 3,000 patients included in this analysis. What was, first of all, found that risk for first appropriate ICD shock in 597 patients out of those 3,000 from the registry analyzed was quite high. If you look at figure on the left, if you look at 4 years or 6 years, numbers underneath, you see 14, 18%. So it's pretty high risk of really life-threatening event in this patient population. And left graph is summarizing the overall cohort. On the right, we were looking at subgroup of patients. And the top curve represents non-fatal cardiac arrest, so as we sometimes call it aborted cardiac arrest. And over here, we see that the risk is very high. Syncope on beta blocker is the second curve, which is very much following the previous one, similarly to what we reported almost 20 years ago, but now with much larger data set. And interestingly, when we look at cohort of syncope of beta blocker, but with QTC significantly prolonged, these people also have high risk. And this is really category which might be still disputable, whether they should get ICD after first syncope, not receiving beta blocker, but having quite prolonged QTC. At least over here, looks like risk is similar, somewhat lower, but still high enough in this patient population. So what we did analyze effect of ICD in mortality first in entire cohort. As you see some numbers in this table, we speak about 389 deaths in 3,035 patients. And what we learned that ICD patients versus no ICD patients in this cohort using so-called multivariable adjusted analysis for variety of covariates shows about 46% reduction in mortality. The second line is mortality sensor at age 50. Why we did it? Because obviously after age 50, people may develop coronary disease, hypertension, a number of other comorbidities that could affect people with or without long QT, and those may influence mortality. And as you see, when we censor people at age 50, so focus on those younger people affected by long QT, 71% reduction was observed. And when we look at only sudden cardiac death, not just total mortality, but sudden death, also about 78% reduction. These particular findings are very stunning in terms of huge reduction in overall mortality. What we did next, we look at effect of ICD on mortality in patients by indications. And as you see over here, aborted cardiac arrest, which is, as I mentioned to you, obvious indication all over the world, 86% reduction. People who had syncope while on beta blocker, still 73% reduction. And syncope while off beta blocker, but having this QTc above 500, very significant, very substantial 58% reduction. Let me disclose that the last group, when we analyzed the people below age 50, was also showing about 50% reduction, but p-value was slightly above significance, didn't reach fully significance. So one could still argue whether this type of people should receive ICDs. What's also important that, let me just present both graphs, that risk of first appropriate ICD therapy in this patient cohort was high, about 20% by about 6 years, as you see. On the right, there is risk of inappropriate ICD shots. What are inappropriate? It means that this device is reacting to arrhythmia, which is not really ventricular arrhythmia it's supposed to treat. There could be atrial arrhythmia, it could be regular rhythm of the patient, but simply very fast. It could be some issue with different counting of so-called QRS and T waves. And these graphs on the right is showing from that publication a reason for inappropriate therapies in 300 long QT patients. And as you see, unfortunately, about 50% of those events are lead malfunction and similar electrical issues with the system. Another 20% is so-called T-wave oversensing, it meaning that the device is looking at QRS and looking at T-wave, as Dr. Wilde was showing us, and device is thinking that QRS and T-wave are two adjacent QRSs, so the rate is fast, and therefore it delivers shock for this kind of situation. So as you see over here, there is definitely room for improvement by manufacturer of these devices, because those 70% or so caused by those technical issues should be and could be eliminated with progress of technology and novel approaches to programming. Let me finish with this summary slide that we believe that ICD is life-saving therapy, beneficial in well-selected high-risk long QT population. I quote here 10-year risk of appropriate therapy is about 23%, but 10-year risk of inappropriate therapy is also 23%. I should add that still, if you speak about rate of appropriate therapy over 10-year, over 100-year years, 100% years, it's about 3 times higher for appropriate than inappropriate. And these inappropriate therapies rarely in this patient population cause significant adverse events in terms of mortality. And as I mentioned a moment ago, definitely we need to improve technologies, and research needs to be prompted to reduce the risk of inappropriate therapies. So I will stop here